we've been delighted to welcome many current former Stanford residents to our program. What do you think about the fellowship training in general, and how do you advise your residents?
Well, I say this just like you, as somebody who not only sees the training from a program director standpoint, but I was a resident and fellow here myself, and I can certainly say, dating back to then and ever since, I think that the fellowship training here is outstanding. What you really have is that mix of a busy clinical service with everything that really ranges from bread and butter to truly tertiary quaternary type cases, and then just an absolutely world class research at every level of the basic translational research, clinical research, and population health sciences, and there are very few places where you can marry those two quite as well as at Stanford.
Talk a little bit about the clinical enterprise. You're a very active attending in the CCU. What is that experience like for the fellows especially?
Yeah, I'm biased, but I think it is one of the highlights of fellowship, and I think most of our fellows will say so. The goal is to really have the cardiology fellow running the CCU. I mean, the attending is, of course, there to provide oversight, but we really want the fellow to take charge and really run the team and come up with the treatment plans. The nice thing about the CCU is that it brings everything together. It brings your cath lab training together. It brings your imaging training together. It certainly brings your critical skills, care skills together all in one. And I think it's often a real highlight for the fellows.
Your virtual background is the brand new Stanford Hospital sitting behind us. How is that changing the CCU and your clinical practice?
I'll tell you, 500P is of course, we call the new hospital for its address, 500 Pisteur Drive, is remarkable. It was amazing seeing it built over years and years and years, and just anxiously awaiting what's it going to be like when it opens. It's an amazing building. It's of course got all the bells and whistles and all private rooms and those sorts of things you wouldn't even think about. It's quiet. Patients can get rest. Being in the hospital is such a dehumanizing experience in many ways, and I'd say 500P humanizes this dehumanizing experience as well as any place I've seen. But the other thing that's really nice is that basically the J Tower, which is one of 4 towers, is for cardiovascular medicine and surgery, and so you can go directly up and down to the cardiothoracic surgical ICU, the CCU, the step-down units, and the cath labs, and so everything is within easy walking distance or up and down a flight of stairs, which is really, really nice, and easy access as well to consultants if we need to pull a surgeon in quickly to a room, et cetera. It's been really phenomenal.
You also have a very active outpatient clinic and have had for many years fellows in your clinic. Tell us about the outpatient clinical experience with you and what they can expect.
Yeah, thanks for continuing to place fellows in my clinic. It's much appreciated. So my clinic is a heart failure clinic, but then I also sort of subspecialize in 3 areas: amyloidosis, cardio-oncology, and sarcoidosis. And for the fellows, I try to give them some of those cases, but of course, we want to expose them to the breadth of cardiology. And again, I'm biased, but I think a heart failure clinic is really perfect for this, because again, when that patient comes, it really matters what the cath film is like, and do they need to be revascularized? It really matters what do they have valve disease? What are their PA pressures, et cetera? It really sort of brings it all together. And we have incredible nurses who work with me and the fellows in the clinic, and it's just a great team effort. I've been lucky to have wonderful fellows over the years, and look forward to having a couple more join this year.
For many years, I've been impressed with this close relationship we have, collegial relationship, not only within the division, but also with our colleagues in CT surgery, and that's sort of epitomized in this cardiomyopathy conference that the fellows benefit from. Why don't you tell us a little bit about that?
cardiology program, to some extent, can only be as good as the surgical program that also supports it, or vice versa. You need to have a really close collegial relationship. You have to have surgeons who are ready, willing, and able to operate from anywhere from the bread and butter to the really high risk coronary type things. We really have that here. We have an incredible group of surgeons. For years, we have had a conference that's called the Cardiomyopathy Conference, although it's not just about cardiomyopathies. It's really a joint cardiology, cardiothoracic surgery, and cardiac imaging conference. And it is a pure case-based conference where one of the faculty or fellows presents a case. We go over the imaging, we discuss it, and a lot of times that's how decisions get made. Or we bring a case saying, well, gosh, do you think we should operate here? Do we think we should do such and such interventional procedure? And it's just a great forum to have everybody there to discuss. We typically go over, anywhere from 4 to 5 cases each time. And it's a very, very clinical conference, very high yield. I think it's been one of the fun conferences for fellows to attend for many years.
Yeah. One of the things that you've established here, and I talked to Kevin Alexander actually a little earlier today, is a world-class amyloid center. And I also know that you have interests in cardio-oncology, which is a burgeoning field. Can you talk about your research interests, your clinical research interests, and how that might benefit, especially the fellows?
I have been very, very fortunate to be at Stanford, and I feel like the sorts of things that I do, I get to really take advantage of a lot of what it has to offer. What I mean by that is, I love cardiology and heart failure as a field overall, but I've also had the opportunity to really focus on some niche areas and collaborate with others to build programs. So the 3 areas I focus on, again, first is amyloidosis, and we founded an amyloid center shortly after I joined the faculty, actually. And for amyloidosis, of course, this is a group of diseases that are really systemic. And to take the best possible care of patients, you can't just have a cardiologist or a hematologist or so on and so forth. You need a host of clinicians from various specialties. And if you're going to go a mile, you want to be able to do basic and translational research in that area, or have people on the team who can, and you want to be able to offer clinical trials to patients and to help move the field forward. And so we've been able to build really one of the largest amyloid centers in the world, and we have all of those components. So we have a tremendous basic and translational science group led by Kevin Alexander and Ron Liao, who was his mentor. They're both out here. We have a wonderful colleague in hematology, Michaela Liedtke, and then a host of other clinicians. And between the cardiology and hematology side, we have many clinical trials and have been some of the leading enrollers in some of these clinical trials worldwide. In cardio-oncology, obviously a multidisciplinary field. The nice thing about Stanford, one of the things, and I like to tell this to the residents too, is that Stanford's every bit big enough to have every opportunity you can want, but it is not so large that you get sort of lost in the shuffle, and people know one another, and putting together programs like joint things between cardiology and oncology is much easier to do than I think a place 3 times our size where people just don't know one another as well. And so cardio-oncology has been a very much growing field, period, and again was something that I got involved with really as a fellow, and then starting as a early faculty member, and it's been amazing to see the field develop over that time, and to at least be a small part of that. And now it's a big area of interest of many of our fellows, and in fact, one of last year's graduates, June Rhee, who's now on the faculty, it's one of her main areas of interest, and then 2 of the fellows who just graduated, Hanju, Paul Cheng, both joining as attendings, and it's large areas of interest for them as well. And Han is a wonderful example, as is June, of not only approaching it from the clinical side, but also having a real science component to it laboratory science component to it as well. And then sarcoidosis was an area of interest as well, and we basically recapitulated what we did on the amyloid center side to do the same with sarcoid. So we have a rheumatologist and pulmonologist who co-direct our sarcoidosis program with me, and we have an amazing nurse who is in charge of it and who pulls everything together, just as we have two amazing nurses on the amyloid side. So, you know, again, really good examples of what Stanford's all about, being able to bring people together from different disciplines into teams and hopefully make some real positive changes to fields.
You touched on a couple of those physician scientists, those junior trainees, and you know, we've collaborated closely on the translational investigator program, the short tracking program at Stanford, and I feel like this is really in Stanford's DNA. As the medicine program director, maybe talk a little bit about the importance of the TIP program in you know your view.
The pool of physician scientists in this country has been shrinking, at least of people going into it. And it's really a crisis because this is how our fields advance. We need fantastic clinicians to take care of patients, but we also need the science side to help move the fields forward. And you know, Stanford isn't the only institution, but it's one of a fairly small handful of institutions that can really do this really well. And that has the pluses of being on a single campus where you can walk down the street and be in the engineering quad, and then you can walk down the street further and be with bioscience or biodesign. You know, obviously, world-class basic research. And it's all within a stone's throw. And in a culture that, as I was getting at before, is a place that isn't so big that people get lost in the shuffle. The DNA really is here, working across divisions, departments, or schools in the university. So from the residency program side and fellowship program side, I think all of us in the department are aligned about the importance of recruiting and training physician scientists who will be the next generation of leaders in their various fields. And over the last few years, we've had really tremendous success in recruiting outstanding physician scientists to Stanford for residency. And then, of course, most of them stay on for fellowship.
Now, one of the big supporters of the physician scientist training program and the fellowship program in general has been the leadership of the Department of Medicine. And we're lucky to have a cardiologist, a world-class physician scientist cardiologist, Bob Harrington, as our leader. So why don't you talk a little bit about how that has influenced you know, cardiology and fellowship training and residency training?
Yeah, well, I mean, it doesn't hurt when the recent president of the AHA is your department chair when you're a cardiologist here. Not surprisingly, Dr. Harrington has brought in talent from around the country, in some cases around the world, to Stanford, and he's the sort of person who seems to know everyone in academic cardiology, that opens up resources. It opens up opportunities for junior faculty, for trainees, and you know, again, the sorts of people that he's brought in, like Ken Mahaffey, to really build up the clinical research program at Stanford. I mean, it's just tremendous. He's an amazing leader. I've learned so much from him in so many aspects, but maybe in none other as much as just getting to observe somebody who has just incredible leadership skills and is able to bring people together and really move things forward. He did it for the AHA, and he does it week in and week out at Stanford. So it's been incredible.
And one of the people he's just recently brought on is our new division chief in cardiology, Eldrin Lewis, right. Who's bringing you know, I've interviewed Eldrin and speak to that. I mean, he's going to be part of your group in heart failure and really a world-class clinician and researcher.
There's no doubt. I mean, we had great leadership of our division before with Alan Young and Tom Katermos for many years. They had done it for a very long time, and ultimately decided to move on to other roles. And we had a search where we had so many great candidates come through, and just could not have been happier when Eldrin Lewis was named and obviously accepted the role of division chief. his prior institution, he came from Brigham Women's Hospital, and I know a lot of people there. And after he had accepted the job, everybody A was jealous, and B said, "Oh my gosh, everybody's going to love him." And of course, it's true. He's he's the sort of person who is so talented in so many different domains. Obviously, a very accomplished researcher, a very skilled clinician. And sort of what I was saying about Dr. Harrington as well, a outstanding leader, somebody who brings people together. And he hasn't been here that long yet. It's been, I mean, he's, as of when we're doing this interview, it's only a matter of months, not years. But he's already, you can already see the mark that he's making in our division.
One of the things I also wanted to highlight is something that's near and dear to your heart and mine and Bob certainly is the issue of diversity and inclusion, especially in cardiology. Yep. And I think Eldrin is going to bring incredible, expertise in that regard. But we have, lots of efforts in that area. You're intimately involved in some of them. Why don't you speak to that for a few minutes?
Yeah, I mean, this is a big priority. Well, I'd say in medicine and academic medicine, period, but it's definitely a big priority at Stanford. It's a huge priority of Dr. Harrington's and Dr. Lewis, and I know of yours and mine. Cardiology is in some ways behind even many other fields in internal medicine. It certainly is when it comes to gender equity in the field. It's a passion I know of Dr. Harrington's of saying the percentage of women who are in cardiology and academic cardiology is really in some ways shameful, and particularly in some subspecialties like interventional and EP. And he's committed. I know Dr. Lewis is committed. I know you're committed. I know I'm committed to changing that. That's one aspect, but it obviously goes well beyond gender and race, ethnicity as well, and the groups that are traditionally underrepresented in medicine that have been tremendously underrepresented in cardiology, and that has to change. And so some of it is having to be a clear, stated, intentional priority of the institution, of the department, of the division. And then two is what can we do to attract the best talent to Stanford from across all groups, and then to support everybody when they're here. So there's been a lot of initiatives at the university level, the school level, the department level, to say this is a priority, and how are we going to make it happen?
That's I think
that's and I'll just say that at least in one metric, in terms of having a more balanced gender breakdown, Stanford cardiology, I am proud to say, has been better than most. Not as good as we could be, I'm sure, but better than most over the years. And again, we can I think do even better. But it's something I'm proud to say Stanford at least has a good track record on compared to some peers over there.
You've gone from being a mentee to being a mentor, and have mentored many cardiology fellows, including some current cardiology fellows. What do you view your role as a mentor?
Yeah, it's not to try to talk them all into going into heart failure, although it's a great field. But no, I think for many of us, I know it was true for me, could be happy in many different fields. So it's not, thankfully, choosing good from bad. But ultimately saying, as you look down the road in your career, not just the next 5 years, but the next 10, 15, 20 years, what are the things that most inspire you? What sort of work can you do that will prevent you from burning out in 5 years or 10 years? Because if you find areas that you love doing, I think that probably prevents burnout as much as anything. So for me personally, getting to to really have a part in all three parts of the tripartite mission of academic medicine, of clinical care, education, and research. To me, that's great so much fun. It keeps things interesting. Things are constantly changing, and that was, I ultimately realized, was really important to me, and my career went forth as it did. And I try to encourage residents and fellows to think similarly. Okay, what is it that you really love? What is it you really prioritize? You have the advantage of being at a place like Stanford where there's going to be all these doors open to you. What really do you most enjoy? How can you ultimately plan a career that's fulfilling, not again just for the next 3 to 5 years, but for the next 40?
Yeah.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.